The following audio-supported podcast is intended for informational and educational purposes only and is not intended as medical advice. Please speak with your healthcare professional before making any treatment decisions. The guests on today's show were paid to participate in this podcast.
Hey Thal Pals, it's your fellow patient advocate, Nina Marie again. I'm here with co-host Dr. Kevin Kuo, and you're listening to Thal Pals, the Alpha Beta Revolution, Season 2. Hey Kevin.
Hey Nina Maria.
Great to see you again. How are you?
Pretty good. How about you?
I'm great, and it feels so good to be back in our studios for another recording. This episode's topic is iron overload, and we have an expert on iron overload today to talk about the matter, and that would be you. Shall we get started?
You know what? I think you're embarrassing me by saying that I'm an expert. To tell the truth, I'll tell you who's the expert. People like you, the patients.
I guess this is going to be a good episode then.
Agios is a biopharmaceutical company that's fueled by connections with patient communities, healthcare professionals, patients, and each other. Building on these connections and the company's unmatched leadership in the field of cellular metabolism, Agios is pioneering therapies of genetically defined diseases, a broad group of rare and more common diseases that are typically severe and life-threatening. Near term, Agios is focusing on hemolytic and acquired anemias, including sickle cell disease, pyruvate kinase or PK deficiency, and thalassemia. To learn more, visit agios.com. That's agios.com.
A lot of patients may know that we keep an eye on iron and that we take chelation to get rid of excess iron. But can you break down what iron overload actually is?
So before I get into the iron overload, I'm just going to step back and talk about how our body works with iron, okay? So I'm going to take the audience back to the Stone Age, even before the Stone Age, hunter-gatherer, okay? We're on the Serengeti right now. A saber-toothed tiger is coming against us. Elephants are charging at us. What do? We run, of course. We're going to hurt ourselves because we don't have clothes on. We don't have our Nike Air boots, etc. We're going to bleed, okay? The early humans, I'm talking about 100,000 years ago, we're bleeders because we bleed by cutting, we bleed by trauma, etc. We probably didn't even live till 30 years old, okay? People die probably around the 20s or something like that. Now, at that time, as you can see, because of the way we're losing blood, and iron, as you know, is an essential part of building the hemoglobin, building blood. So our body that has evolved to conserve iron as much as possible. That is why our body has no natural mechanism to excrete iron. Like we cannot pump iron out of our body. We can only absorb it. And so on average, we absorb around 1 to 2 milligrams of iron. And this is even true for women who are menstruating. And then we also lose around 1 to 2 milligrams of iron a day. And that's by usually the shedding of the skin of the gastrointestinal tract, like your guts. Now, your guts is just like any other skin, it sheds. And when it sheds, you lose a little iron that way. Very little, as you can see. 1 milligram is like nothing. Now, you can imagine then when someone gets transfusion. Now, how much iron is in a bag of blood? 200 milligrams. And on average, actually, let's not even talk about average. Nina Maria, how many bags of blood do you get?
Typically 2 to 3.
Okay, typically 2 to 3 every month?
Every month, every 4 weeks.
So that means you are getting 400 milligrams to 600 milligrams of iron.
That's a lot.
Every month. And imagine, we only have the ability to lose around 1 to 2 milligrams of iron passively every day. So on maximum, that's 30 to 60 milligrams of iron. That pales in comparison to the 600 milligrams of iron you get every month. Now, where's that iron going to go? It doesn't get anywhere, right? Because you get blood through intravenously. It goes directly into your body and it gets stored in the liver. And when it gets stored in the liver, it builds up. And when it builds up, eventually it's going to get to a point where it says, I'm completely overflooded. I don't have any more place to put it. Then it starts going into places like the heart and the pancreas and et cetera, et cetera. So that's in a nutshell what iron overload is.
Okay, and so this iron that we're getting from the transfusion, is on top of the iron that we already have in our system, like you said. And if we're taking chelation, can patients with thalassemia still get iron overload?
Yes, that's a very good question as well. So, actually, before I go into that, I also want to mention this to all the audiences is that even if you have non-transfusion dependent thalassemia, because of the anemia, the low hemoglobin, and also because of the way in which the body of someone with thalassemia cannot make blood effectively, so this is called ineffective erythropoiesis, because of those two things, that people can also have iron overload even if they're not on transfusion. And by taking chelation, theoretically, it should get rid of all the irons. In fact, in some people, iron chelators work very well. The problem is that, of course, there's always side effects with iron chelation, right? And you need a lot of monitoring. We've got to keep track of where the iron is. We've got to make sure that you're not getting side effects from the chelators and so forth. And that takes a whole host of stuff that you need to do. So maybe I'll flip it back to you, Nina Maria. What kind of monitoring do you do for your chelation in terms of like scans and blood work?
Most importantly is communication with your doctor and being knowledgeable of these types of things and what kind of numbers we need to monitor. I think the most important tool in life is information and knowledge, and that goes for a spectrum of things, including one's health. So I think understanding what the numbers mean and keeping track of them ourselves. And on top of that, self-monitoring your body. No one knows your body better than you do. Knowing when you feel off, keeping track of things that just don't feel right or if you don't feel well, and communicating that to your doctor.
I couldn't agree more, Nina Maria. And there's so many things that you as a patient needs to keep track of. And so that's why it's important to proactively ask your doctor and say, hey, what's my liver iron concentration like? Hey, what's my cardiac T2 stars like? And so on and so forth.
Absolutely. Understanding what those things mean is super important. And speaking of monitoring ourselves, what are some symptoms that might indicate a patient has iron overload?
Surprisingly, and you probably know this as well, Nina Maria, is very few symptoms until things are really, really, really bad. It's one of those things that sort of sneaks upon you insidiously. And I think this is why we all emphasize monitoring so much. And correct me if I'm wrong, what I think is the most difficult part for all patients and clinicians as well is accepting the fact that here you're doing something day in and day out religiously to prevent something bad from happening, but you yourself don't necessarily feel the benefits because, as I said before, the symptoms really creeps up on you.
Absolutely. And I think that's something to really highlight here. While patients with thalassemia, at least transfusion dependent, we might feel symptoms when we don't get treated. But when it comes to following up with our chelation, like you said, there's no symptoms that follow for a very long time. It's very easy for a patient to lose track and to feel like maybe it's not a big deal if I skip a dose or a week or whatever it is. But the fact is, it is a big deal because you won't know until it's far down the road. And I think that's something we can never emphasize enough for our patients out there is just take your chelation because it is important.
Mm-hmm. So today's episode is called Iron Will. So where do you find your iron will, Nina Maria?
Great question. Wow. I think I find my iron will in my support system, in my healthcare team, in my parents, in my friends. I see how much they care and they emphasize the importance of it. And it makes me want to make sure that I do a good job, not only for myself, but for them too. And I think on top of that, just the inspiration of wanting to live a full life and have quality of life that everyone else does, knowing that taking these pills is going to help me achieve that.
And to the audience, where do you think they can find their iron will?
Within themselves. I think any goal you have in life, your health needs to be priority so that you can achieve all of those goals. And you can achieve all of those goals if you put your health in priority and if you have iron will.
I asked too many questions already. I'm going to flip it back to you.
Sure, my turn again. So let's talk about when it does get to be that point that we haven't been taking chelation, it's too late, we have iron overload. Is there a way to treat it, and what is that treatment, if so?
There's certainly many degrees of iron overload. We usually will use the term like mild, moderate, and severe. And what we try to find, all of us, between the patients and the clinicians, is to find a balance. Because ideally, what you want is you want to take just enough chelation so that you can maintain the same iron as you do before. Low amount of iron, but you want to maintain that. You don't want your iron to drop too fast. You don't want your iron to go up too fast either. Because if your iron goes up too fast, obviously, we just talked about the damaging effects of iron overload. It can go into your heart, damage your heart, go into liver, damage your liver. But then you don't want it to drop too low either, because if you have too little iron, then you can have side effects from the chelators. And so it's like finding that Goldilocks zone. And I think that's almost like an art, I think, than science. And this is why I think it's important that there's constant communication, as you previously mentioned, between the patients and the doctors.
So then chelation really is the key all the way through.
Yes, exactly. Steady does it. Because some people, when thinking that it's a sprint, they're very adherent, they go on very high doses of the iron chelators for a short period of time, and then they get exhausted mentally and physically, and then they stop taking it. That can often lead to problems because when you're on very high doses, you can certainly get high chances of getting side effects. And then if you don't take it, then all the iron is going to build up again. And then I think psychologically also is very, like, you feel dejected, right? You feel very sad when you feel like you're not making any steps forward. So often I'd say just steady does it.
Absolutely. Balance is key to all, right? So what kind of tests and monitoring can patients expect their doctors to be doing?
So the current standard, which is established by the Thalassemia International Federation, as well as the many guidelines that are available regionally in the States, in Europe, in UK, Canada, and so forth, mandates that we should have monitoring of the liver iron as well as the heart iron. For the liver, most part, we use MRIs in places where MRI is available. In places where MRI is not available, that's usually we use ferritin, as you know. For the heart, we use what we call cardiac MRI T2 star. It sounds fancy, but what it is really is just another heart MRI, except that the radiologist will program the machine in a certain way to capture the signal. And that's what the T2 star means.
And how often should these tests be done on patients?
So for the liver MRI, usually is yearly. For the heart MRI, if there's no evidence of iron overload in the heart, we usually would do it every 2 years. If there's evidence of iron overload in the heart, then it really depends on the severity and whether there's any symptoms and what sort of treatment the person is on. And that can range anywhere between every 6 months to yearly.
As we continue to emphasize keeping in communication with your doctor, what are some things that our listeners out there that patients should be asking their doctor?
I think, first of all, is about, does the doctor feel that their dose is adequate, is enough to treat the iron overload? Also, asking the doctors to explain some of the numbers, which I think we're going to get into in an episode, right? What's in the number? But it's important to make sure that we all look at the trends as opposed to one number in isolation, and to also look at it holistically. Because often we would see jumps in the ferritin, and often that's a representation of, say, having a little cold, or if it's a seasonal allergy. Even those things can bump up your ferritin by quite a bit. And then the next month it's going to fall again. So you really want to look at the trend as opposed to just one value. And also is in discussion with your clinician. Like, if you're having trouble, don't feel bad about expressing that you're having trouble with taking your chelators. We're not here to judge. We're not some judge examiners or executioners. We're just here to chat. And ultimately, we want that dialogue so we can understand and help you to be able to take your chelators effectively. And often, like, I'm not a preachy person, I don't like to preach, because I know exactly that you guys completely understand what chelators mean, what are the side effects, what iron overload and what the devastating effects of iron overload. I don't need to preach any of that. What I want to know is what's preventing you from taking your chelators. It could be because you're on a night shift all the time and you don't have a steady meal. And because you don't have a steady meal, then you won't be able to take your chelators, or maybe you're having stomach pain because of taking your chelators. I've had patients who've had so much side effect that they weren't even able to work as a result of taking the chelators. I don't want to end up in that way and then having you come to me and say, oh, I'm not taking my chelators because I just lost my job. So we want to prevent those scenarios from happening. And the best way is just to be open and frank. And then we solve the problems together.
I love that. I want you to repeat one more time what you said about doctors are not here to judge.
We're not. What's our goal, right? Our goal is not to be sadistic and say, Nina Maria, you're a bad person today. You haven't taken any of your chelators in the past 7 days. We're not being paid to do that, right? We're not trained to do that. We're trained to help people. And if we're trained to help people, all we want to do is understand why you're having trouble taking the chelator, and then we go solve the problems together. And then if we can't solve it, then we find other experts that can help us.
I just want to make sure that we hear that, because I think no one really thinks that doctors are judgmental, but I think as patients, we don't want to disappoint our doctors. We know that they care, but I think it's good to remember that it's okay if you messed up. Just be honest about it. Be honest with your doctors. That's one of the best things you can do for yourself, because they're not trying to discipline you or judge you. They want the best for you just like you do. So just having that, knowing they're not going to be mad, they just want the best for you. So be honest.
Nina Maria, I think partly we in the medical professionals are to blame as well in terms of language that we use. I'll give you an example. We often say so-and-so patient failed on a chelator. It should be the other way around. It's that the chelator has failed the patient. You didn't fail the chelator. It sounds superficial, like in the sense that we're talking about phrasing here, but I think phrasing matters a lot because it conveys what our thinking is.
Absolutely. I think that's super important. And yeah, like you said, the patient actually tries and it didn't work. That's not on them. That's not your fault. That's the medicine, the procedure, whatever didn't work. And you work with your doctor and you find another solution.
That's exactly right. Yeah, that's the limitation of the chelator or limitation of that treatment. It has nothing to do with the patient. Everybody is different. And we know that. Otherwise, you don't need doctors, right? You can just go to ChatGPT and say, hey, cure me.
Maybe one day, right?
I'm not so sure, man. I'm not so sure if I want AI to take over my health.
I would agree with that one. So once patients have their chelation down, first and foremost, is there anything additional to chelation that can help with patients' iron? I feel like I've heard conflicting things about eating red meats or iron-rich foods. It adds to the iron. It's not a big deal. What can you speak on that? Is there anything we can do outside of our chelation once we have that down pat to help with our iron?
It's very tough. There are many chelators out there. I don't think we've violated any rules, to tell the truth, personally, because we just use chelator in general, right? But really, chelation is inextricably linked with iron overload, unfortunately. So it's hard to talk about the diagnosis without talking about the treatment because it's a continuous process. And like other diseases where you're diagnosed with one thing and then the rest is just purely treatment and then you get well afterwards, here is an iterative process where the person is constantly being threatened by the iron overload, and ergo, there's a constant management and adjustment of that management, which then leads to the further diagnosis as well and so forth.
Kevin, once a patient gets iron overload, what kind of complications and specifically to each organ might that patient experience?
As I mentioned before, with the initial onset of iron overload, it can be very insidious. Most patients don't have any symptoms. In fact, initially, when people get iron overload, the damage doesn't occur immediately, especially in patients who are non-transfusion dependent. When they get first diagnosed with iron overload, they get really alarmed. And I tell them, you know what? Yes, we got this diagnosis, but it's not life-threatening immediately. It's not like the next day you're going to get all the complications from the iron overload. It's just that if we don't treat it, then in, say, 5 or 10 years, then you're going to start to develop the complications. So what are they? So I'm just going to run the list. With the liver, if there's too much iron, you can get hepatocellular carcinoma, which is a type of liver cancer. You can get a thing called cirrhosis. Cirrhosis is basically irreversible damage to the liver. Now, funny enough, the liver is actually one of those organs where it can regrow and regenerate itself. Imagine you cutting off like a salamander, you cut off the limb and then it can grow back again. But that's like what the liver does. But there's a breaking point when the liver can no longer repair itself, and that's called cirrhosis. Then, as I said before, once iron gets completely topped up in the liver and there's no more room to store the iron, then goes into the heart. And in the heart, of course, you can imagine the way the heart pumps is that it uses electricity, and the electricity is conducted through the heart, and that's how it causes the muscles to contract. Now, imagine you start throwing in bits and pieces of iron in there, you're essentially short circuiting the heart there. And this is why people get what we call arrhythmias or irregular heartbeats. And they can come in things like atrial fibrillation, and worse, they can get like ventricular tachycardia and all these fancy terms, which is essentially very bad things that are happening to the way the heart is pumping. And if there's too much iron, you can imagine iron is strong, right? Literally, you can actually make the heart stiff as a result of too much iron. And when the heart gets stiff, it can no longer pump, and patients can enter heart failure. And then the iron, because it's spilling out of the liver, can also go into other hormone producing tissues. We call those, in general, endocrinopathies. That's a fancy term essentially for problems with tissues that makes hormones. What are the tissues that makes hormones? The pancreas, for example, is one. And of course, if iron gets into the pancreas, then it can cause diabetes. It itself, of course, can lead to a whole host of other complications with diabetes. When your nerves are damaged, your eyes get damaged, your kidneys get damaged, etc. And then the iron can also get into a very tiny organ that's located in the brainstem at the base of the skull, and it's called anterior pituitary. It's this tiny little thing, right? It's maybe less than an inch. It's small. But what it does is that it's a place where a lot of different hormones are made, especially hormones that controls things like estrogen production and testosterone production, and things like thyroid, right? Thyroid is the regulator of building a body and helps us with sleep, wake, and just good general health. And it can really mess up with these hormones. So if it gets into the anterior pituitary, and the pituitary, because it's so small, it can get damaged easily. And without estrogen, of course, then you lose your bone health. You have difficulty with your menstruation, and you will have difficulties with having kids and so forth. So you enter early menopause. For men, same thing. If you have testosterone, then of course it's going to affect the general health of the male sexuality. And of course, if it affects the thyroid, then you get what we call hypothyroid. And if you get hypothyroid, you're going to be very sleepy, lethargic. You're going to have dry skin, constipation. You're going to hair. You're going to lose your hair. So these are not fun things to have, right? And this is why we always, I know it sounds judgy now, but it's not judgy. Like we just keep pushing for people to be more adherent to the chelation. It's all because of those scary things that can
Absolutely,
happen.
because it is important. And I think it's easy to forget, like we said, because you're not seeing anything happen, but just hearing that list of things that could happen, that's just a reminder to patients. It is important. It is a big deal. A question, so you listed all of these things that could potentially happen depending on which organ iron might deposit on. Is that kind of a random thing, like which organ gets more, or does one happen first before the others?
That's a wonderful question, Nina Maria. So I compare the way iron overload is like, imagine that a child goes in your kitchen. I don't know if you have any small cousins or whatever, or nephews, runs into the kitchen, starts turning on the faucet. What happens? The kitchen sink fills first, right? So imagine that kitchen sink is the liver. So that gets filled first, and then what happens if it keeps filling without someone noticing?
Spills out onto the floor, onto the counters.
Exactly. When that kitchen sink is filled, i.e. the liver is filled, then it spills onto the floor and so forth. And then, of course, you're going to scream bloody murder, right? And you can imagine that those are like the heart and the endocrine tissues, the hormone producing tissues.
Whatever the iron finds first.
Exactly. So you go to the liver first, and then it's the heart and the endocrine tissues.
And like you had mentioned, iron overload is reversible, but these repercussions are not. Is there a specific time window in which a patient has to reverse the iron overload?
Yeah, I think it depends on the degree of iron overload. Obviously, the higher the liver iron concentration, the worse the T2 star is, the more urgent it is to reverse it. So it's this gradient of risk.
All right, I think that does it for our iron overload episode. It's been a great episode. Kevin, again, great chatting with you. I hope our audience out there really enjoyed it. And if you did, please share with your friends, your family, your community out there, and continue to tune in. We'll see you next time.
See you next time, everyone. Great seeing you, Nina Maria.